What is up, everybody? Joshua Smith here, and we are here with another Ask Jim and Jay episode hosted by me personally, Joshua Smith. So we release this information, this show exists, and we've created the show to go out there and drop the right information, a lot of great knowledge on you guys so you can go out there and level up inside your health, fitness, nutrition, and overall optimize your health and your body and take it to the next level. So real quick before we jump into today's show and today's content, I just want to give a quick plug to Jim and Jay's newest book, which is the Metabolic Blowtorch Diet. So this is an advanced strategies intermittent fasting program that allows you to go out there, maintain muscle, even gain muscle mass while shedding off and stripping off that body fat. So this diet is absolutely insane. It's what Jim and Jay and even myself now personally am on. This book is free, right? So Jim and Jay are given a free copy. You just got to pay for the small shipping and handling fee. But if you go to metabolicblowtorchdiet.com, so www.metabolicblowtorchdiet.com, you can go and get your free copy today. So make sure that you go check that out. All right, you guys, let's jump on into the show. What is up, everybody? Joshua Smith here with another Ask Jim and Jay show hosted by me, Joshua Smith, where every single week we come at you guys live with nutrition, health, fitness, just hardcore tips that help you go out there and optimize your own, again, health and fitness and go out there and live the most optimized life that you possibly can. So today, you guys, we are jumping into a multi-part session. About 2 weeks ago, we released on YouTube part one discussing our golden rules. So the golden rules, just for those of you that are watching this for the first time, are with Jim and Jay's new book, the TOT Bible, that will be released soon in about the next month or so, based out of everything that's inside that book. So you're talking about 500 pages of just insane information in that book. These were the top 20 golden rules that they came up with based on all this information. As long as you get these 20 things right, you're going to have big success when it comes to your TOT optimization. So this week, we're going to be hitting on 5 through 9 of the golden rules, and we're going to get jumping on in. You guys ready?
Let's do it.
All right. So and real quick, if you guys missed session 1, we'll have a link of that below in the comments. So just click on that link so you can watch session number 1 of this, where we shared the first 4 golden rules. So gold rule number 5, testosterone optimization therapy done correctly uses testosterone only to establish a baseline for your blood work and correctly evaluate your vital biomarkers. So you guys want to elaborate on that?
Go ahead, Jim.
Yeah, so a lot of times we'll see a clinician that will take a patient and start them on 3 or 4 medications at once, such as testosterone, anti-estrogen, HCG, and I just find that it's hard to evaluate what's really going on and how the patient's going to predict or how the patient's going to react to the testosterone and if AI is even needed. So we like to, and some of the clinicians that worked on us with the book, like to start with a monotherapy first, such as testosterone, see how you react, see what the estrogen response is going to be, and then treat accordingly to that. I know that, HCG is thrown in there a lot of times because whatever the protocol of the prescribing physician for fertility or, perhaps saving fertility for the future is. But a lot of times we just see that, when you start, for instance, with an AI on top of that whole protocol, then it takes forever to get tuned in. And a lot of times, you're spinning your wheels, getting these false readings, because your body kind of equalizes when you first start TRT. A couple things happen and it tends to level out, and then you get a truer picture if you need something like anti-estrogen. So our theory is that we like to see, therapy begin with as many or as minimal amount of variables as possible.
Yeah, I would just add the issue that we see, and obviously Jim hit pretty much every nail on the head. A lot of physicians, and we feel that this is going to be strongly corrected with the TOT Bible when it comes out, because Jim and I went really, really deep on this in many, many points and places in the book. I think Jim kind of said it right. A lot of physicians are unfortunately trying to make money in this crazy Obama Affordable Care Act day and age. And so they're prescribing other medications / chemicals with testosterone initially when guys start therapy. And it's impossible to get a really, good baseline, as Jim said, when you're looking at multiple chemicals instituted in a person's endocrine system. So unless a guy has like a real clinical need to maintain fertility of using HCG or HMG or maybe both in combination with testosterone, our belief is that testosterone should be the only agent in isolation when it started out. I mean, there's really no need to be running all these other chemicals, at the same time, because there's no way to get a true baseline. There really isn't. So you're not going to know how testosterone in isolation, by itself is affecting your endocrine system individually as a human being if you've got all these other chemicals like an AI, like a SERM, clomiphene, HCG, other stuff that sometimes doctors will prescribe willy-nilly because they think it's part of their initial protocol when a guy starts testosterone. I mean, we totally see the need and the value of maintaining a guy's fertility, clearly, especially for younger guys in their 30s and 40s on testosterone. But, we really do believe that you can still maintain fertility and at least look at a guy on testosterone for 4 to 6 weeks to see how they respond much better than you can with an AI, with HCG, other things that may or may not be prescribed, pregnenolone. I mean, there's a lot of other things we could talk about that affect endogenous chemical and hormone function. But that really is the best way to administer testosterone. If you talk to any of the top physicians today who really have a lot of experience, and when I say a lot of experience, we're talking decades of prescribing testosterone, prescribing hormones, and they're going to tell you to your face that the only way to really get a true baseline is to be looking at things in isolation whenever you can. So that's golden rule number 5, as hardcore as we can make it. I mean, that's about the best way I can say it.
Yeah. Now, how long? Because it seems like these have such a quick impact on the body. How long? If somebody's just starting out with TRT, like how long is enough time? I mean, is it a full 90 days, or can you get a good baseline in 5 or 6 weeks? Or how long should you start with that one protocol until you get that baseline and see what else may or may not be needed?
That's a good question. Go ahead, Jim.
I'm thinking the 4 to 6 week mark. Maybe it depends. Some people react differently, but I would say, if you're doing the shots right too, if you're doing at least biweekly administration, you're not doing anything like a once a week or once every 10 days shots. I would say I would hope within the 4 to 6 week mark, your estrogen is going to find its new balance with the added testosterone therapy, and then you're going to have a more clear picture if you need AI or not. And that's the problem that we see. A lot of these guys, a lot of the docs just have a protocol. Hey, you walk in the door, you qualify, great. You get 150 milligrams this and 1 milligram of AI, and see you later, man. Seen 6 months for your blood work, and that's just not the best care that you can get.
No, it's not. And Josh, I think again, Jim hit the nail on the head. I mean, it depends on who goes first. The reality too is the delivery system does matter. As Jim said, very rightfully so, injectables are going to optimize blood levels or stabilize blood levels definitely in the fastest way possible, especially if the physician is giving a dosage, milligram equivalent that's necessary. It's hard to know though, as Jim said. 4 to 6 weeks is a really good general number to understand what's happening to a person's estrogen, to understand what's happening to a person's hematocrit, to understand what's happening to a person's hemoglobin, and the biomarkers that we should always, or physicians should look at very closely and intimately. But I mean, there are guys too that are on transdermals or pellets, unfortunately, God forbid. And those take a lot longer. Some of those guys, you're not going to really see a really good understanding of and we didn't mention PSA, the transient increase in what happens in prostate from testosterone, which is obviously, in the book, we're very hardcore on that. It's very harmless. There's very little risk in using testosterone if you're otherwise normal to the prostate. But, all these things are going to take, I think you said it too, Josh, in the beginning, and Jim's right. I think of 4 to 6 weeks in the minimum to a 9 to 12 to 15 weeks at the maximum. It's going to give you a really good understanding of what's going on internally in your endocrine system as far as like the reactions that you're having. You know, when I spoke to Rob, Dr. Rob Komenarik, who's obviously very instrumental, who's going to be coming on the podcast, I think, with us in February. I've got it all dialed in. You know, he said that some guys take 3 weeks. You know, some guys that are following a healthy lifestyle and, you know, just had that issue as they got older are dialed in 3 weeks and they have no issue. You know, you start them out with one chemical and they're good. But then other people, fatter guys, he said, you know, he calls them metabolic emergencies, take longer because there's a lot of broken pieces in the body. And so these individual components, you start introducing chemicals, whether it's one chemical or two chemicals or three chemicals, and a lot of things can go wrong.
And it also depends too, if the prescribing physician nails the testosterone dose right on the first time. Yeah. So a lot of times, rightfully so, you know, you start out at a conservative dose and that may or may not work based on, you know, a lot of things, SPGH or whatever, you know, it could or could be a large enough dose of testosterone. And if it's not large enough, then you have to adjust that and then wait for things to equalize and see, you know, and then evaluate the other factors. So
agreed.
It is patient dependent.
Right on. So that brings us into golden rule number 6, which is about aromatase inhibitors, which usually we refer to as AIs, which is a medication that helps manage your estrogen, right? So higher your testosterone level goes, a lot of times you see a spike in your estrogen level. So these can help lower your estrogen. But AI medications are only used when there's a clinical need to do so based on your blood work and pronounced side effects. AIs can cause serious negative effects to bone mineral density over time. And, you know, when you look at most physicians out there, at least from my experience with most of them, it just seems to be such a natural protocol. And they seem to get very heavily prescribed, more so than not, you know, and it just seems like most people aren't educated on those long-term negative side effects.
Yeah, so I'll for this one. So this is, I think, and I know Jim agrees with me, this is probably like the one mode of contention that we're really bringing forward in this book that we believe is going to really alter / shake up the landscape with physicians, because unfortunately, and we know many of these guys who are great doctors in their own right, they're starting out guys on AIs with testosterone when there's absolutely zero clinical need. You know, they're doing it from a legally CYA standpoint because their attorneys are mandating it, or, you know, as I won't mention the names, but, you know, Jim and I have heard from numerous physicians that they get the calls, you know, from men in the middle of the night who've been on therapy for 2 or 3 weeks that their right nipple's itching or blah, blah, blah. And so, you know, to not have those calls, they feel like, well, if I script them a blanket aromatase inhibitor medication, such as an Arimidex, you know, at the beginning of therapy, then I won't have those calls. But here's the problem, okay? The problem is, and Jim and I know this because we've seen this so many times, and we've heard this from other doctors. If you don't have a clinical need for an AI, okay, and how the hell does anybody know if you have a clinical need for an AI unless you're a really, you know, metabolic emergency, a very clinically obese person who starts testosterone for specific medical reasons, and you already had elevated, you know, estradiol symptoms, E2 levels. Other than that, okay, where there's an, again, established clinical need before the starting of testosterone therapy, there's no possible way that you can effectively evaluate that person on testosterone, again, in isolation. That's the best way to describe it, until the testosterone gets into this, you know, the bloodstream and starts doing what it's doing. It's magic. So, you know, giving them another chemical like an AI with a testosterone at the very beginning is pointless. I mean, and again, we're going to ruffle a lot of people's feathers. You know, Jim and I know we're going to get into a lot of debates, a lot of arguments. But again, the best physicians that are doing this the longest, who have been obviously intimately counseling me and working with me, you know, in the book, working with Jim, we know how this is done. And giving somebody an AI when there's no clinical symptoms, there's no need necessitated, there's nothing that indicates they need it, it's bad medicine. And again, we're going to offend a lot of people. I wouldn't be surprised that over the next three days, I'm going to have doctors writing in attacking me for saying that. And that's fine. You know, we're moving forward, we're pressing on, and we're, you know, putting new concepts into the marketplace. But for anybody who's smart in administering testosterone, this is not new concepts. It may be new concepts in the big picture because it's not put out there like it needs to be, and there aren't a lot of great doctors doing it this way. But this book is definitely going to be pushing to the mainstream. Go ahead, Jim.
Well, and let's review too. AIs aren't harmless medications. They're not risk-free medications. I mean, you know, we've been advocating minimal usage, if any, for forever, because that's what we've utilized in our own therapy for 20 years.
Well
done. But you know, with Dr. Rob's data, I mean, this is the first piece of data that we actually have from a practice-based physician who has gathered all this information, and it's discernible proof that this ain't good. No. When you have men that are on testosterone demineralizing bone density, that's bad. That's not good, man. No. And so, and then when you ask somebody, well, what's the magic number for estrogen? It's their opinion. There are no hard facts like, oh, it has to be between 20 and 35, because if you go over 35, this will happen. If you go and believe 20, this will happen. Well, we know when estrogen gets too low, you eventually crash and feel awful. There are some people that respond to a higher estrogen number, but it's patient specific. And, if you can avoid taking another dangerous medication, because AI is now what I would put into a higher risk category, class of drugs than ever before, because we have this new data, I would say try not to take it. And if you do take it, take as minimal amount as possible to get the desired results, meaning you're out of your symptom zone of high estrogen.
Yeah, Jim. Well said. I'm glad he brought that up, because he caught what I didn't say. I mean, Rob shared with me, and obviously it's his perfect timing, right? Because Rob's podcast just ran this week. And Rob went really, really deep on this. And he even went after a lot of physicians, God bless his soul, who are doing this wrong, saying, look, I have the evidence, as Jim brought up. I have, literally a large size patient population where I've seen guys who have been on Arimidex for a year, and they've got like the bone mineral density of old, an 85, 90-year-old guy who's never lifted weights before. And these are people that are in shape. He was talking about people that are like, lean and trained. So yeah, it's a really harsh chemical. We have to realize that these are chemicals that are made for women's cancer patients. Okay. Not men, women who already have, cancer. I mean, remember, a woman's estrogenic ratio compared to a man's is like way off the charts. I'm not going to get into numbers, but women have a much greater percentage of the estrogen. They have better sensor receptivity to estrogen. And these are chemicals that are designed for women's, systems, right? So when guys are taking these, that's why they have to take micro doses. That's where we have to be really careful. Physicians have to be monitoring things. And, one of the things that they haven't been monitoring in the way they needed to are like DEXA scans. Now, obviously, there's people out there that will say, oh, well, DEXA is not the standard and blah, blah, blah. But at the end of the day, if you're a physician and you're prescribing testosterone to people, you have to be, cognizant of all these different effects, of all these different factors. And giving a guy an AI when there's not a clinical need, just because you're afraid, it's not the right procedure. It's not the correct way to go about things. And again, I will debate any physician on that. I have no problem if they want to say, well, hey, you're not the doctor, and you don't have to deal with these patients calling me when they get itchy nipples or whatever side effects that may or may not come from, elevated estrogen. But I mean, again, you can use an AI. We're not saying that you can't use an AI, but it can only or should only happen when there is a clinical need. And we say this in the book very, very closely, the goal should be a minimum effective dosage of the AI, right? So it should be a minimum effective dosage to get the patient out of the side effects and the symptoms, and to get him off, to wean them off, to titrate therapy to a point where there's no necessary reliance on them. Because again, we know, as Jim said, they're extremely harsh.
Now, if there is a minimal need and, some guy that's listening to this is on it for a clinical reason, and the amount that they need to balance it where it needs to be, because there's a clinical need and it gets the estrogen at the level that it should be, are the side effects then just as bad, or is there a way to counteract those? Because if I'm listening to this and I'm on an AI for a clinical need, man, I'm going to be kind of freaked out.
Yeah, I haven't seen Dr. Rob's research, to go over it with a fine tooth comb, meaning was there a dosage relation, or was there a dosage relationship based on, how much bone demineralization was noticed? I don't know the answer to that, Josh, but, just rule of thumb is, for me, it's always been with drugs. is take the minimal amount that you need to get the desired effect.
Absolutely.
And so, eventually, I mean, like we've seen with a lot of clients, a lot of guys, is you titrate your dosage of AI down to the smallest possible amount to keep you out of the symptom zone. And that's it. If it has to be that, it has to be that. And that's after you optimize your testosterone therapy, meaning you're taking more frequent injections, more frequent, smaller injections. You're losing body fat, everything that you can do to naturally, or as up to that point, everything that you can do to minimize estrogen production, and then titrate your dose of AI, and so that you're taking the least amount as possible. But when you have grown men on testosterone replacement therapy who are performing resistance training exercises, losing bone mineral density faster than the regular population, there's something really wrong, man. That's major, dude. That's a big, to me, a big no-no, man. That's bad.
Josh, that Jim Brown guy is pretty smart character. I'm glad we partnered up with him. I mean,
in my closet studio.
I honestly can't really say anything better than that. I would just say that he hit the nail right on the head. I'll just be more blunt. And again, Dr. Rob, has been very gracious in mentoring me on this. And by the way, John Chrysler agrees. I mean, there's other doctors. This isn't just like, I'm not going to just give all the credit to, Dr. Rob, but I mean, obviously Dr. Rob and Dr. John are the two guys that present at AMAG. They are the thought leaders in the space, along with Dr. Neil Rougier, who's not in this, not in the book. I mean, he's in the book and that mentioned, but he's not part of our science team. But that's only because him and I don't know each other. But I will say this, and Jim said it. I'll just be much more blunt because it answers. Because by the way, Josh, your question's the best question. You literally should be modulating your testosterone frequency, as Jim said, right? So if you're on one shot a week or twice a week, and you're having estrogen-related issues, high estrogen-related issues, you're either one of two things. Your either dosage is too high, or as Jim said, it's too infrequent. Again, why we want more frequent shots? Because it mimics the body's natural pulsatile release of testosterone. So the thing that you would do is you would lower your dosage initially. So if let's say you're 200 milligrams a week, then most likely you're going to drop to 175, maybe even 150, depending on how long you've been on that dosage, and change the frequency of the administration. Okay? Doing those two things, you're then going to draw labs, staying exactly as Jim said, if you're already on the minimum effective dosage, and then slowly, if not surely, withdrawing the dosage of the AI completely, and then, again, noticing how you feel. Because it's always not just the lab measurement numbers, right? It's how you feel. It's how do I feel? Am I balanced? Do I feel great? Am I ready to take on the world? And Jim's right. And, I had this very deep conversation off the air with Rob about this and in the conference. And he said, look, most guys don't want to hear this because they don't want to know that they're taking too much, right? Like you tell a guy on 200 who's like awesome and, feels great about it that he's got to come down to 175 or 150. And a lot of those guys are going to push back, especially like he calls them type A's, like people like us. He's like, no, doc, I don't want to lower my dose. But the bottom line is that may be what's necessary to get you to a point where you're balanced and you don't need an AI. But Jim's right, dude. An AI is a harsh drug, man.
That's a great point, Jay. And I just had this discussion the other day. The difference between having like a 700 total T and an 1100, if they're both equalized, okay, because when you drop from 11 to 700, you're going to have 14 days of difference, right? You're going to have a lower sex drive, and then things are going to equalize again. But all things considered, linear dose to linear dose, and you're at 750 to 11. It's not like you're gaining 10 pounds more muscle a year or some shit. You're getting 10,000 more hard-ons. I mean, it's the same. You can't tell the difference, man. The difference is between, when you feel good and you're in that zone, and then when you're out and when you're low and you have the symptoms. That's the difference. The difference isn't between 700 and 1100. You're not going to, you're having all these Superman, type things. That doesn't happen, man. That's between 700 and 5,000. That's a difference. That's something that you can tell. And that's, obviously super physiological doses of testosterone. When we're talking about the range between 500 to 1100 and you're symptom free and everything's fine, it doesn't matter. You're fine. So you want to minimize, again, take the minimal amount of drugs to get the desired effect. And if you can cut out taking an AI by lowering your total test just a little bit and still be in that zone, I mean, absolutely, dude, because again, it's in my opinion, it's a dangerous chemical, and you have to minimize your exposure to it, period. That's it. I mean, we have the proof now.
100%.
And don't you think too, for a lot of dudes, it's obviously we always want the shortest path to success, right? Like I'm trying to hack everything, and it's like, dude, it's so much quicker just to jump on the AI than it might be. Because your estrogen can be lowered through, so massively through diet, losing body fat, through cutting out alcohol and different things. You think for a lot of dudes, it's just, they just know they're not disciplined enough to make those changes, where it's just the AI is such a simple, or maybe the physician doesn't have faith that they're going to be disciplined enough to make the right changes to lower the estrogen.
Both.
That's a good point, man. But you have to consider, man, this is not just a therapy for the next 2 years or, the next 6 months. This is a lifelong therapy, man. When you start on testosterone, it's because you have a clinical need and your body's not producing enough, and you've already maximized lifestyle changes and it doesn't work. And so when you start TRT, you're on it forever. So this is a long, slow ride. TOT. When you start this ride, man, you're on this train till it's over with. So it's worth time. It's worth the time now to dial in the dosage and get it right. To maximize everything. And if you talk about, okay, I'm just going to be lazy and take the anti-estrogen and not worry about the other stuff. Well, let's accumulate that over the next 5 years. How much, unnecessary chemical have you been exposed to?
Right.
Because you don't want to take the time and titrate it right and do it, correct it in the beginning. So I would just remember that this is a lifelong therapy. It's something that you're going to be on forever. You might as well tune it in and get it right, man.
I agree, man. Can't be said better than that, dude.
Yeah, love it. All right, so now we're on to golden rule number 7. So the usage of medications to increase luteinizing hormone, so your LH levels, such as HCG, HMG, clomiphene, and consequently raise testosterone levels without disrupting your body's homeostatic mechanisms. So the HPTA/HPGA axis, I don't know what the hell any of this means, should normally be the front line treatment with men who are prime reproductive age, so 18 to 35 years old.
So Josh, you were that guy, right? So here's the thing. Let me just back up with that. So on that point, let me just summarize that, because it's obviously a lot of endocrinology and molecular bio in there. But the HPTA is the body's homeostatic mechanism inside men for the hormonal axis, right? This is what maintains stability, maintains balance. We have a chapter 5 in the book is on the biological understanding of male endocrinology. It's very basic, but it's very, very cut and dry, very clear to the point. When you're starting out young, and this is probably one of the most important points in the golden rules because of the environmental siege, right? The issues that we have in the environment. Josh, you're a perfect example. You were a guy in your early 30s. You were doing everything right. You're smart. You're hacking your body. You couldn't believe it. I told you, I'm like, bro, I'm telling you, so many guys, you went and got your testosterone and you're like, holy shit, right? My testosterone is 260 or whatever it was. So then, you went down the medical route, and this is where the problem is. And it's not a problem. Doctors are doing and following the law and following the rules of current modern day society, but you have to go down this path of first use chemicals that can potentially increase your body's natural production of testosterone, which is what you mentioned. You mentioned human chorionic gonadotropin, which is HCG, HMG, which is human menopausal gonadotropin, and then the last one is clomiphene, which is another medication. It's a pill form that can stimulate LH, which is luteinizing hormone, to increase the body's natural production of testosterone. Now, all of these chemicals / medications are necessary for men to maintain fertility at the same time they're using testosterone. So the real point of that message is that in the current system, in America especially, and really globally, it's established for physicians to not disrupt the body's natural production of testosterone through, exogenous supplemental testosterone. And it's a better route to start with those other chemicals. But Josh, as you learned, and again, we're all different, we're all unique, there's no one size fits all approach. Those did not work as well on you as using testosterone. So the issue becomes if a guy comes in today who's 26 years old and he has 220 testosterone, which, is a very, very, normal probable case now, especially in large coastal population centers. What is a physician to do? Well, according to the book, according to standardized medicine principles, if you want to call it that, there really is no standard patient care for hormone therapy, but they're going to go down the least invasive route, which is through HMG, through HCG, through clomiphene first, to see if they can get their body's production of testosterone higher while attempting to maintain fertility. So that's kind of the standard issue. You found out, Jim and I talk about in the book, many guys are finding out when they go through this that sometimes testosterone with those chemicals together is a better solution as far as well-being, as far as energy, all the great things that we love about testosterone, than taking any of those things in isolation. Did you want to say anything, Jim?
I'm going to skip this because I have a lot to say about HCG that I probably a whole different thing. So
you're going to hold back?
I'm going to hold back. I will say that, there are patients out there that, they've been working on a new, like a microdosing protocol of Clomid.
Yep.
There's some guys that's what that works for. They're not very many. They're not a lot of them, but there's some guys that have success with that. It's worth a try. Before you start, injecting testosterone, I would again, eliminate all the lifestyle variables that you can. And then, try to kickstart your system with something like HCG that's a viable theory, by all means. Because once you start on testosterone, you're on it.
Yeah. Well, with things like Clomid, right? Like when I first went on, before they put me on synthetic testosterone or the injections, they had me on Clomid and DHEA, dude. And yeah, my blood work, I guess my levels went up and looked decent there, but I don't think I've ever felt worse in my life, dude, right? I felt like hell. And I don't know this because I didn't stop that. I went from that to then doing the injections. But I would have to assume that once you get your levels normalized or back to a normal level and you stop that, won't they just go back to what the baseline that they were when you started this journey anyway at some point?
Well, the only story that I have is relevant to that is there's been bodybuilders who've been using exogenous, testosterone and other anabolics. They come off, they go through a period of, 6 to 7 months with their normal testosterone, the HPTA not turning back on, doing some type of protocol with an HCG and HMG to kind of kickstart their own system, and then successfully that somehow jumpstart their system and gets their body to start producing testosterone again. Now, I personally don't think that taking HCG, is going to, I think it disrupts the HPTA, but that's, I know that's disagreeable to a lot of people, but that's been, somewhat documented. There's been enough people that have said that has worked. So I believe that. But for a guy that's, in the low 200s or whatever, kind of giving it a jump start to see if it's going to fix without changing lifestyle or anything else, I don't know how successful that is on its own, other than, taking HCG and getting a rise in testosterone out of that, and that gets you out of the symptom zone. But I would assume that, if your level is compromised and you're at like 300 and you have symptoms, you've corrected lifestyle changes, you try to jumpstart it, something like that, then yeah, once you stop taking HCG or Clomid, you're going to go right back to where you were, unless something, unless you were really suppressed somehow before, like using, exogenous anabolics and your systems crash, but then your number would be lower. So I don't really know. I don't know how successful that is of, somebody coming in presenting with low numbers and then it kick-starting, and then they're in they're in a range where they're symptom free from now on. I don't know. I do know that the younger guys that we've talked to, or patients that we've been made aware of that are on a microdose version of Clomid, have had numbers raise, and they feel good, and they're in that symptom-free zone. But I think that's just a Band-Aid for the inevitable. It doesn't correct the system. It doesn't fix the problems to where there's an end game where they're going to go off of it. It's a delay to injecting testosterone.
Josh, this is such a good topic. Let's stay here for a second. Even if we don't get through all of them, that's fine. Because
we call it a bridge.
I want to bring the mean stuff out of Jim. I want everybody to see the true greatness of Jim. Listen, Jim and I are very staunch, very advocate, very outlandish. I'll say it right now. We do not believe in HCG like a lot of people in the community. Jim and I have a lot of experience with HCG. As you guys all know, Jim was very close to being a very high-level competitive bodybuilder. He knows a lot about HCG. We have both seen guys who are literally not on anything other than massive dosages of testosterone and anabolics for, decades plus, trying to be pro competitors, whatever, who started HCG and HMG again just when they needed to have kids. And, oh, wow, everything started working again. So the truth is probably, as they say, stranger than fiction. We're all unique. We're all different. But we look at HCG when you're not, again, when you're in your 40s or 50s or whatever, when you're not needing to have fertility to maintain to have kids, that it's just another chemical, okay? And it's another chemical that causes other issues and disruptions and combinations and effects that you don't understand or control, again, compared to like testosterone and metformin and maybe a thyroid, hormone medication and together. That just creates needless side effects. Again, we're very outspoken. It's very clear in the book. We'll say a little bit about it right here. When we use HCG, we get acne. Okay, we get like weird breakouts. We get that emotional instability, that irritability. It comes on like clockwork. Yeah, sure. We get like a bump. We get a little bit of a, there's a dopamine effect. There's like an increased a libido effect. It's very short term. It's not long. But both of us, sure as shit, within 36 to 48 hours of taking it, we get acne, right? Or if we don't get acne, we get unstable. We're like, why am I taking this? So we're all different. There's tons of guys on the boards who will attack me and Jim for saying this. They attacked me today on Nelson's forum about it, same thing. And, they do great on it, or they think they do great on it. So we're all different. But at the end of the day, I am never going to be that guy, as I know Jim supports me, that we're going to like go out there and sing from the rooftops about HCG and how necessary it is. And there are physicians out there that will scream and say that, the receptors all over the body, the luteinizing hormone receptors are all over the body, including in the brain and the scalp and blah, 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 blah. And you have to have, a stimulation through a chemical to make sure your luteinizing hormone receptors are feeling the way they do, to have all these other wondrous effects. And quite honestly, we don't believe that. So go ahead, Jim.
Well, I'll just say this. I mean, the times that I've seen somebody kickstart their system, is post anabolic usage. And that's after, waiting long enough where it should have started producing on its own. And it didn't. HCG and HMG was used to kickstart. But if you think about it, I mean, that's an adjustment of lifestyle changes. I think. I don't think that, that's a combination of massive lifestyle changes, correcting your hormone balance and then maybe it getting a kickstart. But, and I'll only speak for the things that I know firsthand about, and that's one of them. I don't know what it's like to have low testosterone and then try to use one of those monotherapies to get me into a place where I feel good. For me, HCG screws up my testosterone therapy. It creates peaks and valleys where there's steady levels because, as you guys know, I inject every day. I have a very stable sex drive. All that stuff is really tuned in. And anytime that I've ever introduced HCG, it messes that up. Like Jay said, and I've tried the microdoses, I've tried the megadoses, I've tried every dosing protocol that's known to man or that I've discovered yet, I've tried. And, the only use that I have for HCG is like a big weekend. I'm going to Vegas with the wife for 4 days. I'm using HCG a couple days out, and that's going to give me an artificial bump in sex drive. And I know I'm going to pay for it for, 7 days afterwards. But that's okay, because we're both beat up, so I'm good. But that's the only way that I use HCG and feel better. And we've been questioned and challenged on this too. But listen, man, I am not going to take a hormone on some, faith that it's going to do
right.
something for me.
Right.
When I take a hormone and it makes me feel worse, I stop fucking taking it. I know it's groundbreaking, but that's what it is. when you take a hormone and it makes you feel better, then it's probably something that you should take. Most everything that I've taken ever, hormonally based, if I don't get a reaction out of it, it's probably not enough. If I get a positive or negative, then it determines, whether I keep it or consider keeping it or not. And HCG has never added a plus into that category, except for, like I say, a weekend usage. And then, I have a massive valley after that. So it just doesn't have a place in my therapy, but some guys like it. But then again, those are a lot of guys that have started testosterone on that therapy and don't know what solo testosterone's like. Right. And solo, meaning they've given it a chance to equalize out. They're optimizing the injection schedule, all those things. And that's fine too, man. Whatever works for you guys, I don't have an opinion on it. That's just my feeling on HCG. If I was a guy that was trying to maintain fertility throughout, I would donate sperm and get it frozen.
Yeah. And so, Jim, let's say that, because that's a question they get all the time. So they ask us, because obviously, Taylor was on the Nelson's board today, and Nelson already called him out because he knows that's what I recommend to people. But listen, we're all different. Jim and I had kids while we were on testosterone.
Okay. I had kids when I was on a massive amount of anabolics with nothing like no HCG and Clomid either. A massive amount of anabolics.
Right. So I was, very honestly, I was using HMG and HCG, and I was using it exactly as Taylor put forth in the group today. I used 100 IUs, which is what John Crisler recommends, a day, 4 or 5 days in a row. And I did it for 2 months, and I had both of my kids, right away after it in the course of less than 2 years. They're almost like Irish twins. So I, everybody's different. We're not going to sit here and criticize people or harangue people for saying, oh, blah, blah, blah. But I mean, it's like, I agree with Jim, all these guys that scream about how it does all these downstream things. And, it's essential for cortisol. I mean, not cortisol, but testosterone. And, what is the fat, it's synthesis, and it does all these amazing things downstream. And it's like, I don't see it. I'm the same as Jim. I've used it. I've tried it consistently for a long time. I get zero. I don't even get the psychosexual effects that he gets. That's how I was laughing, because I'm thinking there's a lot better stuff than frickin' HCG. So, I mean, again, that doesn't mean Jim and I are 46, 47 years old. That doesn't mean that 5 years from now we won't start it. Nelson is very open about he didn't start taking HCG until he was in his 50s. He's 58 now. So it doesn't mean that, in the course of our therapy that things might not change, and we might see it as value down the road. But as of now, no.
And that's part of it too, Jay. I mean, I retest theories over and over again, as my body changes. So maybe when I'm 58, I'll use HCG too. But right now, and for the last 20 years, right, it hasn't added to my therapy at all.
No, agreed.
And I would say, I mean, you're absolutely right. Do what everybody's welcome to do whatever they want to do. But if you're thinking, I have to have that to have the kids, and that's a guarantee, dude, it's not. Get your stuff frozen. Right. Get it tested. Make sure you have viable. Get it frozen and be over with. Be done with it, man.
No doubt about it.
Because it's a crapshoot.
Yeah. Yeah. I mean, there's definitely no guarantee, right?
Right.
Yeah. So, all right. So leads us into golden rule number 8. There is no such thing as a one-size-fits-all TOT delivery system.
No doubt about it, man. Jim and I talk about this all the time. We laugh, but hey, man, whatever floats your boat, if you cannot bring yourself to inject yourself, you pussy, then it is what it is. You got to use cream or gel. Well, don't use cream, but use gel. There's really powerful concentrated, our good friend Sean Norian, part of the science team, the owner of Empower Pharmacy. What's up, Sean? I know he watches our stuff. They make compounded creams or gels, at like 20 to 25%. I'm sorry, I'm getting it confused. It's creams, not gels. Gels is androgel. Do not use androgel if that's what your doctor is prescribing you. It's weak. It's ineffective. We break it down in the book. We destroy it, honestly. But yes, there's compounded creams that are 15 to 20, 25%, concentrations. And those are just as effective as injectable. But here's the problem, right? And we know this, and again, all in the book, you got to do a lot of work. There's a lot of preparation to use a clean. You've got to shave regularly. You've got to avoid your loved ones, pets. It cannot be around your animals, cats or dogs. It wears off. It can transfer to them, your kids, even your wife or your loved one, your spouse. I mean, so it's at the end of the day, dollars for donuts. Injectable is still the best solution. Obviously there'll be more and better delivery systems coming. There's a company out there with this new auto injector that supposedly is going to make injecting like painless and seamless and instantaneous. So guys that have needle phobia right now, and listen, needle phobia, Josh, as you know, I mean, you're not afraid, but we know this, right? We hear this from guys that we respect, and it's a serious phenomena. There are people that literally cannot inject themselves. They pass out. So if you're one of those people and you just can't do it, then guess what? You got to use cream, and that's fine. But just recognize you're going to have to do more preparatory work to do it.
Yep. Well, and then I mean, it's not even just a delivery system, right? I mean, you guys have elaborated this already on this podcast today, but everybody's level, like I know, like Jay, like you can operate with a higher estrogen level than I can operate at, because I'll start breaking out with acne and other things if and I think at one point, I don't know if it's still true now, but at one point you and I were having a conversation and you were actually in a lower dose of testosterone sipping 8 weekly than I am, right? Even though, I mean, you're bigger, way more muscular, whatever that may be. But for me to get my levels where they need to be on a blood level standpoint, I had to take a higher dose, because I had things like my sex binding hormone being high, which when the doctor first told me, oh, you got high sex binding hormone, I'm like, hell yeah. Right? He's like, oh, that's not a good thing, dude. I'm like, oh, damn. Right? So everybody is so different. Yeah. So my protocol might be, hey, I'm on a little slightly higher testosterone than Jay Campbell. And then I've got to control my estrogen and make sure it's a little bit lower than his, right? To get the same effect, the same result, and the same result in the blood work, but it's not all the same. Like everybody's not going to respond the same exact way to 200 milligrams a week.
Exactly. No, you're 100% right. There's just, again, it's, like this question is the bullet point or the golden rule. There's no one size fits all. And that's why it's essential that you work with a physician who knows what the hell they're doing, as we say in the book, practice-based therapy, experiential-based practice. And, one of the things that we're going to do, Josh, we might as well put it out there right now on this podcast, be the first announcement, is that for all the people that, during our launch week, which is not next week, but the week after, who leave us a very favorable review on Amazon, preferably 5 stars, we're going to give you a badass gift, right? Like Jim and I are going to give you a PDF, like a white paper that'll be all nice with our logos and stuff on it. That'll say, these are the questions that you're going to ask your doctor, right? Decide if they're going to be worthy of working with you. And here's the answers, right? Because the questions are already in the book, but we didn't give the answers out because we felt like that would be a better Chotsky to give out after the fact. So you're going to get that. And trust me, every person I talked to today, the smartest people, in this country, I got an email. I forwarded it to you guys. You guys will read it later tonight, from a really high level attorney in Santa Monica. He worked with the famous physician, Jim, you know who he is, Dr. Carlos Eulis. He's in, muscle and fitness. He's been in muscle tech, the famous bodybuilder to the stars doctor. He just retired in Santa Monica. I didn't even know this, like in December. And so this guy asked me, he's like, who can I go to? He's like, can I go to Dr. Rand McLean, blah, blah, blah. So the bottom line is there's no real answer at this point of like, who's the best doctors to go to. Jim and I and Josh are working on a solution for that. With TRT doctors, but you got to vet your doctors yourself. So we give you the tools, the ammunition's in the book, and we're going to give you the answers that they should be able to answer when you decide whether or not you're going to use them. Because seriously, as we said this before, and you guys know this, you cannot think that you're just going to use your general garden variety, benefits doctor to prescribe testosterone for you, because it's likely they don't have any idea what they're doing, and it's going to end up bad.
Yep. Love it, dude. All right. So brings us to golden rule number 9, which is you must regularly perform blood work and become familiar with your specific biomarkers to assess your overall health when undergoing TOT. So with that, I mean, when you talk about you must perform regular, what does that mean? Can you define that a little bit further?
Well, I would say once you get tuned in, at least a couple times a year, I do a little bit more frequent blood work myself. But when we were talking about before, when you start or initiation of therapy, you're probably going to have blood work done a little bit more regularly. Obviously once to qualify, probably somewhere, I would hope, within the first 3 months to see if there's a clinical need for AI at that point, if it's enough testosterone, if it's stabilized. How your body reacts in terms of lipids and inflammation markers, all those things, and then at least we like to see biannual ones after that, and then if you're titrating an AI dose or you're titrating a vitamin D dose or something like that, obviously you're going to have more frequent tests, but that's not a complete panel. Those are isolated ones. Or if you're keep an eye on your ferritin level, any of those things would dictate you being more having blood work done on a more regular basis. But once you're tuned in, everything's fine. At least biannual, I would say, especially if you're over 38, just to keep an eye on stuff.
Yeah, and it's a great answer. It's all in the book, guys. We kind of go by age, by decade of life, and then also by risk factors. But if you're 30 years old right now and you're a girl or a guy, and remember, the book is written for women too. We have a whole chapter on there on women. It's very, very radical, amazing stuff, leading to Dr. Jim Meehan and Monica's book next year, or actually this year. We're in 2018 now. But yeah, if you're 30 and you're watching this podcast right now and you've never had your blood work done, you need to get your blood work done. Okay. And the easiest way to do it is obviously you can look in the book, but if you're going online, depending on where you live, private MD labs, discounted labs, there's a million companies. Okay. I'm just mentioning those two. You just search, women's anti-aging panel, men's anti-aging panel. What's, if you're pre-TRT or pre-TOT or whatever, those are all there too. Listen, it's a couple $100. A woman, I think it's $180. A dude, I think it's like $239. This kind of stuff is so critical. You cannot go to your general practitioner, garden variety benefits doctor and say, Doc, I'm in perfect health. I want you to do my blood work. I want you to measure my blood work. They're going to look at you like you're insane. Well, you're not sick. Why would I order blood work? Right? So this is preventative. This is, proactive, non-sick care. I need my blood work, doc, because I want to know what's going on inside my body. I want to understand, the hood of my car is up. I want a full comprehensive internal diagnostic. I mean, that's what you're doing with this. So at 30, once. At 40, as Jim said, you're on hormone, you're already dialed in. You should be definitely doing this at a minimum of twice. I mean, again, what's more important than knowing what's going on in your body? And then, as Jim said, if you go beyond twice, it's probably because you've got something wrong. There's probably an internal issue. Maybe you have high hematocrit or high hemoglobin levels naturally. And you want to just constantly monitor that like every 3 to 4 months, which is, very prudent. There's no reason that you should not do your blood work after the age of 35 twice a year. I mean, to me, you don't give a shit enough about your health if you're not.
Yeah, love it. So, all right. So I know we've referenced the book, the new book that's coming out, TOT Bible, numerous times. But Jay, you created a waiting list for the book so everybody can be announced when it finally releases from the publisher, and it's available at that point to go out there and purchase. If those that are watching, listening to, if they want to register, pre-register, and you can't pre-purchase it, but just to sign up for the waiting list to be notified as soon as it comes out. What's the website to go do that at?
So yeah, so there's two. It's a great question. There's two things. The waiting list right now is TOT, so Tom, Opera Tom. So it's Testosterone Optimization Therapy Bible.com, and just go right on there. It's like a landing page. You can just give us your first name, last name, and your email address, and you'll be notified when we launch. I'm 99.5% certain that we will be launching on January 22nd, which is a week from this coming Monday, on Amazon. We have a big PR company that's doing the launch. So you're going to get the opportunity to buy the book, the Kindle digital copy, which is essentially a PDF, for anywhere from 99 cents to $2.99, depending on how heavy it is. The book is a very big book. That's why we call it the Bible. It's close to 600 pages. But it's worth it, man. I mean, as Jim knows, as you know, Josh, I mean, I don't know of a book, and I'm obviously biased, clearly a homer, but I really don't know of a book that really teaches men and women on how to optimize their health in a more straightforward, easy to understand format. This is not like some super esoteric science book where you don't understand it. It's very simple. We have a whole chapter on other medications and other supplements that we use. We talk about like the stuff that's can't miss that you should all be using. I mean, it's truly a badass book. And then the other link I would give them, which I just made in the last couple of days, is just sign up for my newsletter for totrevolution.com, because that's where we're going to be giving away the free Chotskis and free gifts. And you can just easily go there. It's a bit.ly. It's bit.ly.com, TOT So it's TOT, testosterone optimization therapy, and then REV. So Rev, like rev your engines. If you go there on that link, just put your name and your email address, and then that way you're on the mailing list. So, all the free stuff that Jim and I are going to be giving out, that'll come to you too. You'll be notified.
Boom. Badass. All right, you guys. Well, as always, we truly appreciate you being here. Truly appreciate you watching the show. Any questions or suggestions for future topics, make sure to plug those in the comments. We're always checking those, and we want to make sure that we're delivering the information and content that you guys want to hear, that can help you go out there and take your life to the next level. So truly appreciate you guys being here, and we'll see you next time. Peace out.
See you guys. Thank you guys very much.